My name is Henrik Bjursten. I am a cardiac surgeon that has been doing TAVI for 7 or 8 years by now and find that a very exciting area. In addition, I'm an associate professor at Lund University here and have done some research on TAVI and the TAVI population. If you look into what we do with the TAVI, you place a rather big aortic valve with a lot of new structure, leaflets, frame into the aortic annulus, and you leave the old valve there. And we wanted to look whether these patients had a higher risk of developing stroke, given that they had a lot of material in the aortic annulus after the TAVI procedure. We wanted to do this an all-comer study, that is, include all patients who received the TAVI in Sweden from the inception of TAVI in 2008 up till now. And that is, we had that opportunity since all patients are registered in that registry here in Sweden. And the endpoint, we went for the stroke registry that we have in Sweden, which also have a very good coverage, but not complete coverage. We went to diagnosis registry for all hospital stays to complete these sources. And the outcome was being registered as stroke in the stroke registry or in the diagnosis registry. It was defined by the neurologist doing the entering data into the stroke registry. If they had sort of clinical criteria or CT signs of a stroke, it was a stroke. That, of course, meaning that you could miss smaller strokes that was not detected by neurologist or in the hospital. But we needed to have that cutoff as being a hard diagnosis of stroke. The key findings, what we had an opportunity, given that the data set we had, was to calculate a standardized incidence in a population at the same age and the same sex. Those were the only two factors that we could use for our calculation. And we found that the TAVI population had about 50% more stroke than a standardized incidence ratio, sort of a healthy background population. And we also found the diagnosis after, or the prognosis after a stroke differed quite a lot if you had an ischemic or hemorrhagic stroke. The hemorrhagic stroke had quite a poor prognosis, whereas the ischemic stroke had a fairly good prognosis. Of course, you had a 30-day mortality of 20%, but if you survived that period, you were more or less back to a normal survival curve for this population, I would say. Conclusion is that we had an overrepresentation to the standardized incidence ratio in the background population. But then again, this is a sicker population, more atrial fibrillation, more heart failure, maybe more peripheral vascular disease compared to a normal population. So I don't think that it should deter anybody from doing TAVI course, because the option of not doing TAVI is so much worse. I'm not that concerned with the findings that we have an overrepresentation compared to a standardized population here. It does give us opening to doing further studies, but we should continue with our TAVI population. One could discuss whether we should look at anticoagulant regimens or antithrombotic regimens in the long term after TAVI. Much has been said about what should be done the first few months, but very little over time. The next steps will to look to a bigger population. We will increase the data based what has been done lately, and then also stratify patients in low risk, intermediate, and high risk patients and see if the stroke incidence differs between these populations. Given that this is done from patients that are done 2008 to 2018, it's a lot of high risk patients, and of course they will have a lot of strokes. But we want to learn more about the stroke frequency in low and intermediate risk patients also. And at the same time, we hope that we'll get opportunity to match this to a surgical aortic valve replacement population, since we can categorize it into different risk strata, we could have a more fair comparison with the surgical aortic valve population. Take-home messages is that TAVI patients do have a stroke that might be a little overrepresented, but probably it's not a big issue. Overall, it was not a signal that there is a big problem out there, I would say. So we should continue doing TAVI. We might look into studies on a long-term antithrombotic regimen. But in that sense, it's still a very safe procedure given sort of the alternative of not doing TAVI is not an option.